And now I will call upon Dr. Wankhede, who is going to speak about the cataract case. Manish. And Jagatram sir is there, Ragini is there. Also the Parikshit is there. Yes, go ahead.
Thank you very much for this golden opportunity to present in front of all these stalwarts. Today I will present a simple few cases of cataract surgery which we on day-to-day life we practice, and this was a simple dense cataract. Everything was going on normal. I do the Rexis, dense NS3 cataract, normal direct chop technique, and there was nothing in my mind until this step. Even we can see when I put the viscoelastics, the AC was very well formed. I started my bimanual irrigation aspiration. Happy, and then again suddenly the problem start at this step. When I change the hands for bimanual, I see the PC is bulging upward, anterior chamber is getting shallower and shallower. I was thinking, what is this? I try to form the AC by placing the viscoelastics. I start to push the viscoelastic by side port. I remove the speculum, but the PC started to bulge continuously. Then I again put some thicker viscoelastics like cohesive viscoelastic, change the speculum, and thinking what next. At this point, I put more cohesive viscoelastic and try to buy some time. Now my question is how to proceed further.
Now the Jagatram sir.
I think you did very well. Capsular Rexis was excellent. And maybe I think it was in a fast forward mode video,
yes,
but
yes.
it appeared that you did a very, very fast cataract surgery. And while there was I think probably I could not see, I was signing while that point came that whether there was a PCR or not. You removed the cortex also very well.
Yes, sir.
So now we have to see whether there is a PCR, what is the extent of the PCR, and what should be done, whether we can implant the IOL into capsular bag, or whether 3-piece IOL is required or single-piece IOL. That we have to decide.
Ragini.
So basically, I think that the capsular bulge is there. What you have done is correct by changing the speculum, which was causing the pressure. And there is no iris prolapse or anything. Now, your problem is how to insert the IOL without causing a PC rent.
Yes, ma'am.
So you have to see there are what you're using is correct, the cohesive viscoelastic, and to put in the IOL. I think you can go ahead and put in the IOL because the AC is formed right now and the bag is also inflated.
I will ask Dogra sir.
I think retina persons, they think something different. So it could be if something is happening behind, why it is getting so firm and shallow. So I think better to have a look behind and rule out the serious thing before you plan that. Because sometimes there could be hemorrhagic choroidals happening and maybe limited, but then that is what can cause. So, but that is just that being a retina person, we see these things, and I thought I'll just mention it.
If it is there, what treatment you will advise?
Then I would advise to close the eye at this time, because otherwise it's going to be becoming total and kissing, which is a problem. If it is limited, it will go away of its own and you can implant the lens later. Because the closing eye fastest is the best way. That is what happens.
Parikshit.
One is, as cataract surgeons, so we want to think of the cataract, or that's how our brains work. So if possible is to put in a lens quickly and just be done with it and come out, because the surgery has been done well. There is no rent. The CCC is also perfect. So putting in a one-piece IOL shouldn't take more than about 30 to 60 seconds. But if you think that the bulging is too much, then as Sir says, if we have taken an IV access, we can perhaps give IV mannitol on table. That will make the vitreous less turgid and make it faster. But if the bulge just keeps on happening, then the best is just to close it, let it be, and then give mannitol later, because that will still be needed outside the theater, and perhaps do the implant a couple of days later.
Sir,
Basically, when it is getting very much shallower, I have seen that is coming, like there may be a concealed, you can say there may be a concealed hemorrhage type thing may be there. Or if you are now putting the lens, and if there is no space, then also you can tear the PC. One thing what they said is, okay, close the eye, get the pressure control, then you implant the lens. Secondly, you can just give mannitol. Or third thing, you can do the vitreous tap. On one side, you can do the vitreous tap behind. So once you do the vitreous tap, there will be hypotony, and this will help you again. Go ahead.
Sir, can we foresee in which cases we may get this kind of complications?
Can you?
Can we predict before the pre-operative procedure?
Now see, in that, was that a fast forward case, this hour, it was your speed?
No, it is a fast forward, sir. It is 4 times fast
Basically what happens, when you are doing the phacoemulsification, slightly faster. So in that what happens, the lens comes out and the vitreous bulges. It is because of, you can say, the hypotony which is created in the anterior chamber, and that causes the bulge behind. So always better to go ahead gradually. Secondly, the wound leak. Your fluid was leaking from the phaco, you can say, probe, where from you have entered. That was leaking there. So this wound leak can also cause an hypotonus, this one, and that gives rise to shallow anterior chamber. So to avoid, your wound should be proper, there should not be wound leak, and thirdly, you should go properly. Go ahead.
I completed the case by taking the vitreous tap with 26 gauge needle in inferior nasal quadrant. As soon as I took the tap, the AC was well formed, and it was possible for me to place the one-piece IOL in the bag. Many of the times these situations also happened with me. I will like to share one more example. In a similar case, I placed the Blurex dye in the anterior chamber, and the whole of the dye was leaked in the vitreous cavity. Whole vitreous was changed into the blue vitreous, and I had to complete the case against the blue glow, and up to this stage. And this was the final result. Maybe this is also can be set as an example of the fluid misdirection.
Aqueous misdirection.
Yes. About the second case you want?
Yes.
Yes, sir. Second case, there is a vitreous, you can say, when he was stained, that time you can see vitreous in the anterior chamber. Now, how he should proceed? How he should proceed?
This is, you have not still done phacoemulsification. Nothing has been done. I think it is best we inject triamcinolone and do the vitrectomy, whatever vitreous bulge is there, and then we can stain the anterior capsule, do continuous curvilinear capsulorhexis, and depending upon how much dehiscence is there, you can apply even a capsular hook to the capsulorhexis margin to make it secure and firm, that you will be able to do complete phacoemulsification. So I will go like that.
Same, sir. First is to see that whatever is the vitreous that has come in the front is first dealt with, then do a cataract.
You want to add anything?
No, same, sir. There was one point. I think just one point what you asked as to what cases we will probably suspect or would be more vary would be somebody who has a very small eye is where you suspect, because thick sclera, that they can end up with the problems which Dr. Dogra mentioned.
Now, this is the vitreous in the anterior case.
This is the second case I want to present.
This is a?
Second case I want to say.
That is a vitreous in the anterior chamber, no?
No, sir, this is a different case.
This is that was a vitreous.
That was vitreous.
Now this was not vitreous. Okay, go ahead with the case.
Sir, this is another case. In this patient, I have done the pterygium excision and went ahead with the routine cataract surgery. Everything seems to be fine. All the steps were done and all went very smoothly. I have shared few details that even the hydrodissection was complete. It was possible for me to do a complete nucleus rotation, and the whole of the emulsification procedure was smooth and seems to be uneventful for me. Everything went very smoothly until I removed the last piece of the cataract. And as soon as I removed the last piece, I noticed there is a small PC rent just in front of the picoprobe, and the liquefied cortex was going in the vitreous cavity from that part. I was confused that it is a PC rent or it is just a punched out PC rent, because as soon as I withdraw suddenly, the whole of the cortex which was in the vitreous comes slowly in front and the rent didn't enlarge. So to my surprise, it was unusual to have a PC rent and it is not getting enlarged even after doing so many mistakes. Sir, this is my question. Did it was a pre-existing PC rent or it happened during punch out?
Jagatram sir?
I think we must see what is the size of the posterior capsular rent, whether it is a pre-existing or it is done during surgery, and then whether we can implant a single piece IOL or 3-piece IOL.
Yes.
And of course, I think vitrectomy will be required for the vitreous bulge or whatever PCR. It should be made free from vitreous.
If it was an old rent, then perhaps there would be some calcification around the rent to make us show. If it's a fresh rent, that won't be the case. But whatever it is, a vitrectomy will have to be done.
See, the very fact that there is the cortex in the vitreous is that there is a PC which has been compromised. Sometimes, through the periphery also without the PC compromise, you find small particles of cortex in the vitreous, which you can see hanging around. But here, there is a large chunk of cortex. So definitely somewhere the PC has been compromised. One has to wait and not to do any anterior segment manipulations unless you do a vitrectomy, or to do a posterior segment vitrectomy to clear this cortex and then go ahead, which is very, very important. Whether it was present earlier, I don't think so, because like Parikshit Bhai, I would think that there would be calcification and fibrosis around it. Manish?
Was it present before? See, what happens if there is a PCTL, like we get in the posterior polar cataract. So normally this type of PCTL you see in the center, not on one side. Secondly, this type of PCTL, when you see, this is an oblong type of PCTL, not circular type of PCTL. Secondly, if it is an old PCTL, so that PCTL you will get so much of the calcification and fibrosis. Because what you feel is why it is not increasing. So what happens sometimes, if your cortex has gone behind and patient is not having much of the hypertension, or you can say the intraocular pressure is not more, so sometimes vitreous will not come up. So that is a hypotony. Because of this hypotony, vitreous will remain there. And if vitreous is not coming forward, then the TAD will not get increased. So that happens in few cases. You are operating under peribulbar or topical?
Sir, this case was under peribulbar block.
It is normally happens in the peribulbar. You get the hypotony, and because of hypotony, the vitreous doesn't come out. But yes, this is a PCTL, and it is happened because of the, you can say, your aspiration or whatever the trauma it is. And this is a PCTL. So you can do vitrectomy and then implant the, which I will have implanted, 1 piece or 3 piece?
Foldable 3-piece.
Foldable 3-piece. It is always better to implant foldable 3-piece, and you can have an optic capture also if you can do it. Okay. Thank you.